Hello everyone, my name is Phat Amnajtrakul from Bangkok, Thailand. My talk today is transforaminal lumbar interbody fusion or TLIF. So firstly, I have to say thank you, Double Medical, for inviting me to join the presentation. Nowadays, I work at two hospitals. The first one is Smithivet Sukhumvit Hospital, Bangkok, Thailand. And the second one, I am a spine consultant with King Bhumibol Adulyadej Hospital. That is a Air Force hospital in Thailand. So I graduated the orthopedic training program in Thailand and spine fellowship with Professor Michael Meyer in Germany since 2011. And my job, I did a lot of the minimal invasive spine surgery. An overview for my talk today is the first one, introduction, and the second one, TLIF indications and contraindications. And TLIF surgical techniques step by step and result based on the evidence base and case presentation and summarize at the last talk. So for the indication for the lumbar fusion, as we know, lumbar degenerative disease with the instability, for example, degenerative is mixed spondylolisthesis. Only the chronic axial low back pain of unknown etiology. The indication for the lumbar fusion is unclear. The fusion lumbar spine for achieve the fusion that depend on many factors. The first one is the fusion site, and the next one is bone quality, and the next one is systemic factors, and the last one is local factors. So if we do the open long spinal approach and we damage the nerve, we damage the blood supply, rate of the fusion may be decreased compared with the minimal invasive technique. And type of the lumbar fusion, if we do only the posterior fusion, the fusion rate is less than interbody fusion. And the bone quality, the ideal bone graft should be cancellous autogenous bone because it has an osteogenic, also inductive, also conductive property. And for the systemic effect of the patient, that depends. The patient that has multiple medical conditions, the fusion rate is less than the healthy patient. For the local factors, osteoporosis is a negative factor. Mechanical stability and loading, that is a positive, including BMP, that is also inductive factors, also the positive factors as well. Nowadays, we have a lot of technique for the lumbar fusion that depend on where is the approach. If we do the interbody fusion from the front, we call it A-lift. If we do anterior psoas approach, we call the O-lift. If we do from the side, we call the X-lift or lateral lift. If we do from the back, we call the P-lift, or posterolateral fusion, we call the T-lift. So which one is superior than the other one is not clear nowadays. In terms of the fusion or the clinical outcome, most of the literature review the not so clear. But I'm quite sure that interbody fusion has a fusion rate and clinical outcome superior than the posterolateral fusion alone. The history of the TLIF, since 1982, Dr. Ham and Lollinger published the transforaminal lumbar interbody fusion. So they define the term of TLIF as a transforaminal route to achieve the insertion of the interbody case packed with the bone graft. And the indication of the TLIF is a degenerative disc disease, low-grade spondylolisthesis, grade 1 or grade 2, spinal stenosis require the fusion, or the patient has an instability, multiple recurrence disc herniation with the foraminal stenosis, or even the degenerative scoliosis. That is the indicate for TLIF. And about the contraindication, for example, epidural scarring, active infection, anatomical variation, especially some organ For example, the conjoined nerve root obscure the corridor to do the interbody fusion, so we cannot do. And the orthotic patient, we cannot do the interbody fusion as well, or if possible, because otherwise we expose to the graft subsidence or implant failure. The advantage and disadvantage of the TLIF. So as we know, the TLIF easier access to the disc, less injury to the soft tissue, and we can preserve the tension band effect, and less nerve root retraction compared with the PLIF, And the disadvantage, so for the coronal and sagittal imbalance, we cannot restore or correct the alignment from the TLIF compared with the anterior surgery. And the complication of the TLIF, the most common is a duotomy or the infection. Another complication is the same as another interbody fusion. For example, screw misplacement, the case migration. High incidence of the complication depend on how many levels of the TLIF that we need. The incidence is higher in the revision surgery compared with the virgin back. For the surgical technique, the TLIF, the patient was prone on the operating table. And nowadays we have two approaches for the TLIF. The first one is conventional technique, open over the midline and do the bilateral subperiosteal dissection. And the second one is a mini open TLIF. We will do the paraspinal approach, or we call the Wilson approach, to incision. And for the minimally invasive technique, we do the MIS TLIF by the one paraspinal approach, and the other side we do percussionist screw fixation. The surgical technique, step by step. The first one we do the pedicle screw fixation, insertion. The next one we gonna do the facetectomy and working zone preparation, and then discectomy and end plate preparation. Trialing the case, bone grafting, and case insertion. That is the last step. The first one, the pedicle screw insertion. So you can do the percutaneously or open conventional technique. Check with the screw AP, the lateral X-ray. Then identify the inferior articular facet and then cut it. We do the facetectomy. How much of the facetectomy that depends. If you like to release the posterior structure, you have to do bilaterally. And sometimes we can correct the lordosis from the bilateral facetectomy. And sometimes we have to cut some part of the supraarticular facet of the caudal vertebra. And then we do the working zone preparation. After we do the facetectomy, we can identify the ligamentum flavum, and we're gonna do the nerve decompression. After facetectomy, flavectomy, we can identify the dural sac. And then identify the Cambin triangle, that is the corridor for TLIF. Retract the dural sac medially, and then identify the disc. Do the discectomy, and use a disc shaper, prepare the end plate. Case trialing, retract two nerve root. The first one is traversing on the caudal nerve and exiting on the cranial nerve. Me personally, I use the insulin saline filled with the autologous bone graft, put in the disc space. At least 2 or 3 cc is quite good result. And then insert the case. So check the X-ray, AP, and the lateral view for the case and the screw position. And then put the lock and fix it. Final check again with the imaging. So this is the patient that I showed the X-ray. She is 58 years old, fell down and got acute pain on the both legs. So she cannot urinate by herself. For this case, X-ray and MRI demonstrate that she has a severe central canal stenosis of the L4-5 from the huge disc herniation. And from the symptoms or the clinical, she has an impending caudal equina syndrome. If we look at the axial view of the MRI on the L4 or 3-4 facet joint is arthrosis, and the L4-5 she has a severe stenosis, and the L5-S1 she has a disc herniation, left foraminal disc, and compressed nerve on the left side. So this is why I decided to do a 3-level decompression and fusion. This is the disc that we remove, quite big. So after surgery done, we can restore the regional lumbar lordosis from the 20 degree to be 32 degree from 1-level TLIF and 3-level fusion. So the next one is a MIS TLIF. The benefit of the MIS TLIF superior than the conventional TLIF is reducing. MIS TLIF can reduce the blood loss and protect the soft tissue, smaller wounds, and increase rapid recovery, reducing postoperative pain compared with the traditional open technique. This case is 58 years old, present with a lower back pain and neurogenic claudication for 1 year. On the front X-ray, demonstrates that she has a little bit scoliosis on the lumbar spine. On the side view, she has a grade 1 spondylolisthesis of the L4 over L5. This is the X-ray flexion and extension view. So the MRI demonstrates that she has a severe stenosis of the L4 and L5 as well. This is a central canal stenosis. The objective of the surgery for this case, the first one do the nerve decompression, and the second one do the stabilization with the fusion. So I decided to do the MIS TLIF of the L4 and L5. Again, the patient was placed in the prone position, and the first step, pedicle screw fixation, check the landmark of the screw incision under fluoroscopic guidance. And the first target is a facet joint of the L4-5 on the left side. So use a dilator, do the blunt dissection on the muscles, and then insert the tubular type retractor. Check the flow that the tubular is in the good pace along the corridor to achieve the disc. The next step is a facetectomy. As I mentioned before, you can do the unilateral or bilateral facetectomy. If you open as a conventional technique, you can do both sides. But if you choose a MIS TLIF, you can do only one side. Schwab grade 1 or grade 2, that's depend. So if you choose a grade 2, that means a total facetectomy. Maybe you can restore or correct the lumbar segmental lordosis. And facetectomy technique, we have to change the S shape of the vertebra to be the V shape. We cut the facet like this. Here, this is an inferior articular facet resection. Cut it off. The next step is do the microdecompression, do the laminotomy and foraminotomy, use a high-speed burr, and then remove the ligamentum frame. After unilateral decompression was done, so go to the other side. Me personally, I do over-the-top technique for achieve the contralateral lateral recess. This is a video demonstrated the burring at the loop of the lamina to achieve the lateral recess on the other side. After bone work finished, so we're gonna do the ligamentum flavum detached from the bone, and then facetectomy by the Curison longer. Again, after a bilateral decompression was done, identify the disc and identify the cabin triangle again, do the discectomy. That is the next step. Then preparation by the disc shaper and case trialing. check with the fluid and insert the cage. The last step is a screw insertion, rod placement, and do the same on the other side. Okay, this is the postoperative X-ray, the wound, surgical wound, and the second day of the surgery, the patient can walk. The post-op pain is not so severe, so this is the good things. The patient can ambulate as fast as she can. So if we are talking about the result of the TLIF, clinical outcome of the TLIF, most of the literature review that the TLIF will be compared with another lateral interbody fusion. So this is the paper published on 2019. This is systemic review, compare the open versus a minimal MIS TLIF. The data collect since 2005 to 2017. 32 papers is included in this study. Study designed a single RCT. So they focus on the operating time, but loss, length of hospital stay, radiation exposure, complication rate, and pain scale. They choose the VAS and ODI index. So they concluded MIS TLIF reduced but lost length of stay of the patient, but the doctor or the team increased the radiation exposure significantly. And for the fusion rate of the TLIF, review literature, it has some paper published on in 2007. This is level 3 evidence compare the TLIF with the ALIF, and they conclude that ALIF is superior to the TLIF in the restoration of the foraminal height, local disc angle, and lumbar lordosis. Another review is a level 3 as well, published on 2015, compare PLIF with the posterolateral fusion and the TLIF. So they conclude that both PLIF and TLIF have a great result for spondylolisthesis correction and superior than posteral fusion alone. So if we compare the TLIF with the PLIF, this paper published on 2014, 7 comparative observational studies, they concluded PLIF had a higher complication rate compared with the TLIF, and TLIF reduced the rate of delotomy, and no statistical difference between clinical satisfaction, but loss, vertebral root injury, graft malposition, infection, but the TLIF require longer operative time compared with the TLIF. Again, this paper study about the TLIF and the PLIF. So they conclude that open approach may be associated with improved deformity reduction with bilateral facetectomy, probably. If we compare the TLIF with the ALIF, a lot of paper published that for the fusion rate, the TLIF and the ALIF have no significantly difference, but ALIF superior than TLIF in terms of the deformity correction, lumbar lordosis, segmental lordosis. So again, this paper talk about the TLIF and the ALIF go to the same direction. No significant difference in fusion rate between ALIF and TLIF, but ALIF associated with restoration of the disc height, segmental lordosis, whole lumbar lordosis, longer hospitalization, lower dural injury, and high blood vessel injury. If we compare the TLIF with the lateral lift, again, they conclude that any interbody fusion can restore the segmental lordosis change compared with the posterolateral fusion alone. For the radiographic result, this paper published and on the 2009, they focus on segmental lordosis, lumbar lordosis, and disc height, pre and post-operative, and final follow-up. The average time is 1 year. 26 cases is in the study for 1 level TLIF, Only one parameter, that is a whole lumbar lordosis, can restore significantly from the TLIF. Another two parameter, that's segmental lordosis and this height cannot restore by the TLIF in this study. So summarize, TLIF is the one of the most common lumbar interbody fusion. Evidence-based review TLIF have a good clinical outcome and the fusion rate as the same as a lateral lift, A-lift or PLIF, and superior than posterolateral fusion alone. And for the radiographic result or deformity correction, lateral lift and A-lift have superior outcome than TLIF. Thank you.